When a lumbar disc herniates, a highly pressurized, intrinsically avascular structure ruptures directly out into the surrounding epidural space. The resulting mechanical compression and chemical irritation make lumbar disc herniation a leading driver of global low back pain, accounting for massive rates of chronic disability. The established clinical consensus for managing this condition is aggressive suppression. Both the North American Spine Society and Cochrane guidelines overwhelmingly recommend nonsteroidal anti-inflammatory drugs and glucocorticoids as first-line therapies to neutralize the cytokine storms driving radicular pain. This time-lapse sequence illustrates the biological mechanism that challenges the necessity of surgical intervention. In 60 to 90% of extruded or sequestrated herniation cases, the body executes spontaneous resorption, clearing the extruded material completely over several months. Look at the parallel timeline below. When patients are administered early, aggressive anti-inflammatory medication, they exhibit drastically lower rates of spontaneous resorption. The anatomical progression halts, and the herniated mass remains trapped against the nerve root. If inflammation is purely a pathological mechanism that drives pain, blocking it should have no negative effect on physical clearance. Yet silencing the inflammatory response prevents the body from clearing the mass. Inflammation in lumbar disc herniation acts as a precisely programmed essential tissue repair engine. Traditional nonsteroidal anti-inflammatory drugs operate through competitive inhibition. They block cyclooxygenase, or COX enzymes. COX enzymes mediate the biotransformation of arachidonic acid to generate prostaglandins. These prostaglandins are the biochemical messengers directly responsible for activating nociceptive pain pathways. However, prostaglandins execute a secondary function. They are critical signaling molecules for downstream angiogenesis and tissue remodeling. Systemically administering traditional NSAIDs triggers a non-selective suppression event. The drug indiscriminately blocks the pathways generating pain while simultaneously cutting off the physiological signals required for repair. Utilizing systemic NSAIDs for acute herniation trades essential long-term structural healing for temporary symptomatic relief. This diagram maps the peer-reviewed biological model of spontaneous resorption. It outlines the exact transition from inflammatory injury to reparative tissue homeostasis in a herniated disc. The intervertebral disc operates as an immunologically privileged avascular zone. Sudden exposure to the epidural space creates a severe hypoxic microenvironment. Under this stress, nucleus pulposus cells rapidly secrete vascular endothelial growth factor, or VEG. VEG binds to local receptors, activating signaling pathways that command vascular endothelial cells to migrate directly towards the isolated lesion. Endothelial cells migrate into the hypoxic lesion, physically penetrating the avascular tissue to form a functional capillary network. This rapid neovascularization, conduit engineering, is the mandatory first step. It establishes the logistics network required to transport the immune system to the isolated disc material. This graphic demonstrates how the newly formed vascular network serves as a highway, enabling rapid macrophage infiltration. Upon arrival, pro-inflammatory cytokines, specifically TNF-alpha and IL-1-beta, drive these macrophages into an aggressive M1 polarization state. The primary targets of these M1 macrophages are matrix metalloproteinases. They induce the expression of MMP3 and MMP9. These localized proteins operate as chemical shears, designed to directly degrade the thick collagen network of the extracellular matrix. The resulting cytokine storm physically dissolves the structural integrity of the herniated material, reducing the massive rigid blockage into basic cellular debris. Activated M1 macrophages aggressively dismantle the dense extracellular collagen network, chemically dissolving the structural integrity and clearing away the rigid anatomical obstruction. Without this intense catabolic demolition phase, the herniated mass cannot be physically dismantled, leaving the nerve root permanently compressed. To prevent the M1 destructive phase from continuing indefinitely and damaging healthy tissue, the process relies on the release of damage-associated molecular patterns, or DAMPs, via a localized cell death process known as pyroptosis. Specific epigenetic modifications and autophagy enhancers detect these DAMPs. This detection triggers a rapid phenotypic switch within the local macrophage population. The diagram shows the result, M2 macrophage polarization. The immune state transitions completely from aggressive inflammation to focused repair. M2 macrophages secrete IL-10 and TGF-beta, establishing an immunosuppressive microenvironment that neutralizes the earlier cytokine storm. This creates a bidirectional feedback loop. The M2 secreted IL-10 further upregulates VEGF expression, which reinforces the ongoing angiogenesis and accelerates tissue regeneration. The immune response in disc herniation is entirely self-regulating. It utilizes M2 macrophages to automatically pivot the lesion site from aggressive demolition to structural reconstruction. This final section outlines the biological cleanup mechanism, a precisely coordinated network called the apoptosis-autophagy axis. First, the TNF-alpha and caspase-3 signaling axis executes programmed cell death, or apoptosis. This safely clears away redundant or damaged nucleus pulposus cells from the area. Next, the autophagy system utilizes upregulated LC3-2 proteins to act as a cellular scavenger, efficiently routing misfolded proteins and damaged organelles into lysosomal pathways. This highly efficient scavenger process prevents the accumulation of reactive oxygen species. By doing so, it restores the critical enzymatic balance between the MMPs degrading the tissue and the TIMP1 proteins inhibiting that degradation. The synergy between apoptosis and autophagy ensures that all cellular debris is meticulously cleared, restoring local homeostasis without triggering a secondary chronic inflammatory response. This timeline identifies the critical resorption window in clinical practice, the period between days 3 and 14 post-injury for sequestered or migrated herniations. This 11-day interval bridges the gap between peak inflammatory demolition and proliferative tissue repair. The inflammation preservation strategy's core directive is absolute restriction. Potent pan-anti-inflammatory agents must be strictly avoided during this interval to prevent stalling the resorption process. Instead, clinicians deploy alternative modalities that preserve neovascularization, like physical therapy, thermotherapy, and targeted selective nerve root blockades. To address severe patient pain during this period, the strategy advocates for precision modulation. Clinicians utilize analgesics that bypass COX pathway inhibition, avoiding comprehensive immune suppression. By respecting the biological timeline, clinicians safely manage patient pain thresholds while orchestrating endogenous healing. The next frontier of the inflammation preservation strategy moves beyond systemic timing protocols and into the localized deployment of intelligent biomaterials. Diagnostically, multimodal radiomics and ROS-responsive nanosensors will allow clinicians to dynamically phenotype a patient's exact inflammatory stage in real time. Therapeutically, post-discectomy patients will receive microenvironment-responsive dual-network hydrogels implanted directly into the annulus fibrosus defect. These hydrogels are engineered to actively modulate the immune interface. They locally release TGF-beta1 or stem cell exosomes, artificially forcing M1 to M2 polarization at the exact moment required, without blocking the prior healing cascade. The synthetic dual-network hydrogel rapidly expands to physically seal the anatomical defect, while continuously managing the local chemical environment. This highly controlled environment prevents the unmanaged secondary inflammatory cascades and high reherniation rates that frequently follow traditional discectomy procedures. The inflammation preservation strategy represents a change in spine care, evolving from blunt symptom suppression to the precision management of a patient's endogenous healing capacity.